Welcome, everybody. It is Health Talk, sponsored, as Billy just said, by Community Medical Center. We have a special guest in studio. His very first visit to Health Talk, Dr. Stephen Tahta. And first of all, sir, welcome.
Thanks for having me.
I understand that you had an opportunity when you first came to Missoula to study under some amazing teachers, Dr. Uri, some of the other folks over at the International Heart Institute and those areas. So you had some very good training, right?
Yeah, I did, actually. I mean, I was trained well, but I came here because there was expertise in this little town in Montana, which was kind of surprising.
It's amazing, isn't it?
But it was a good start to my career.
Yeah.
I mean, I owe a lot to Carlos Duran and Jim Mowry.
You bet. Well, so tell us a little bit about Dr. Tahta. What is your specialty, and what do you do at Community?
So I'm a cardiothoracic surgeon, which means basically a heart surgeon and chest surgeon. What I did 4 years ago is move over to Community to start a chest surgery service line, because none of that existed at Community Medical Center. And, of course, at the same time, the most important part of being a chest surgeon is the lung cancer program.
Right.
So I started that. I built a unique program where we do minimally invasive thoracic surgery using the robot. So we're the only one in Missoula with a robotic program. And then I really wanted...
The robots are becoming increasingly popular, aren't they?
Absolutely.
Yeah.
I mean, it's developing in multiple different specialties. Thoracic was a little bit late to the game, but now it's incredibly popular and it's growing like crazy. But it was important to start a lung cancer screening program or prevention program. That was a little tricky to do at the beginning because we didn't have approval quite yet from the United States Prevention Task Force. And so Medicare wasn't covering it, commercial insurance companies weren't covering it.
Wow.
It was a much bigger sell back then. Now, not at all, because it's pretty much covered by any insurance.
All right. So go ahead, John.
Oh, I was going to ask you, when you say a service line, I'm imagining like a conveyor belt. So
Yeah.
tell me what the service line is. So you got the robots too. I'm like, are they putting cars together?
No, that's our jargon. So, if a service line is a different specialty, think of it that way. A certain medical specialty has a service line. So we provide those services. Say it was cancer.
Okay, gotcha.
The cancer service line is cancer, any cancer services.
So are there still things that you do with thoracic surgery that you don't get covered for Medicare, Medicaid? Edgier stuff or, that sort of thing?
There are some, nothing that I do, but I have gone through that. There's for example, a diagnostic methodology or technique that was very, very new 4 years ago. Sometimes we'd have an insurance company that wouldn't cover it. So then, we just have to work a bit harder. I got to talk to the medical director at the insurance company and get it covered and give them an argument for why it's a good idea.
Send them to medical school, basically, right? Yeah.
Well, they're doctors too. They just work for the insurance company.
Yeah. They have a different
they have a different take.
A different mindset, right?
That's right.
So let's talk a little bit about lung cancer. Has the incidence of lung cancer, is it increased? Is it decreased? Is it holding steady over the last 10 years? Where are we?
So we're kind of just over the peak. So what we've known for multiple years now is that smoking is on the decline, which is great. It's on the decline, and it's on the decline for men and women. Men are a little bit ahead of women, but basically it's on the decline. The incidence of lung cancer is just over the peak. So, we're seeing it just start to decrease now, which is exciting because we want it to keep going down.
The reason for that, I'm sure, is because if people stopped smoking, say, 3, 4, 5 years ago, they still have the potential of developing cancer from what is still left over inside their bodies. Do people realize that or what?
Not so much. And what they don't realize is it's not 5 years or 3 years, it's 15.
Is it really?
So you only drop out of the high-risk category for lung cancer after you've quit smoking for 15 years.
Wow.
Yeah. So it just pays you back in spades. Your smoking history just keeps on going.
I wanted to ask you about that case that you made for the doctors that worked for the insurance company. What would you say? Like, these are the reasons why we should have this procedure covered. Give us the case.
Well, it's all about the data.
Okay.
You know, that's how I started with the lung cancer screening program. It's all about the data. The data shows that we can save lives with a formal lung cancer screening program. A lot of primary care docs are using a chest X-ray to screen for lung cancer. It's not as good. It's better than nothing, but not nearly as good as a low-dose CAT scan. So, so I had to sell that at the beginning, that a low-dose CAT scan was actually better at picking up early lung cancer than a chest X-ray. The other thing I had to sell was how do we biopsy and prove that something is not lung cancer? So the old way is we used to put a needle from the outside in. The new way is to do it from the inside with a scope. And when that first came out, the standard technique was from the outside with a needle, and going from the inside, which was better for patients, wasn't always approved. So I'd have to sell why that's better. There are less collapses of the lung, you know, less problems, less pain. I had to sell all that in terms of how the procedure was better.
I'm sure a lot of that has to do with coding, right? Because when you look at how you're going to bill from an insurance company, there are different codes for various. I mean, from soup to nuts, there's a code for almost everything.
Right.
But the code existed for the outside in, but not from the inside out. So you kind of had to create a new one.
That's exactly right. I mean, we don't. You know, if I came in after the code was created,
right,
but not all insurance companies were covering it. But you're right. If I had come in even earlier, it would have been an even harder sell if there wasn't even a code to get paid for it.
I have to port over the belly button codes, outies and innies, you know.
That's right.
It's old school stuff.
Yeah.
Okay. Well, we're going to come right back. By the way, lines are open. Do you mind taking some calls from folks?
Not at all.
All right. Dr. Stephen Tahta is with us from the Community Medical Center. He is a thoracic surgeon, cardiothoracic surgeon. If you have any questions or comments about lung cancer or anything to do with what we're talking about today, lines are open, 721-1290. He'd love to take your calls, and we'll be free medical advice. What do you know? We'll be right back in just a minute. Hey, we're back on Health Talk. I'm Peter Christian. That's John King. Health Talk, of course, sponsored by Community Medical Center from day one. Dr. Stephen Tahta. During the break, I was sharing the story of my dad. He was passed away several years ago, but he was in the Marines at age 17, started smoking immediately, went through 3 wars and smoked the whole time. And finally, when he was in his 70s, he got really sick with the flu and laid up in bed for a couple of weeks and, you know, couldn't hardly lift his head. So finally, when he got back up on his feet, obviously he couldn't smoke, right? So he walked into his closet and he came out with his eyes watering. And he told my stepmom, he says, "Dorothy, what is that god-awful stink?" And she goes, "That's your cigarettes. You've smelled like that since we got married." He says, "Are you kidding me? That smells that bad." Very fastidious guy. So he just grabbed all of his cigarettes and flushed them down. Never had another one. Just quit cold turkey. Boom, just like that for 50 years of smoking. Unfortunately, in the next few years, he did develop lung cancer. But it's still important to quit.
It absolutely is. I mean, the younger you are, the more important it is.
Right.
But what I tell all my patients is even though only some people will get lung cancer with this long-term smoking habit, everyone will get COPD. So their lung reserve will deteriorate.
Right.
The tissue gets destroyed. So what I tell them all is, once you stop smoking, you have a chance to level off. Your lungs deteriorating will kind of stop wherever they're at, and that's why it's worthwhile quitting, even if you're never going to get lung cancer.
Sure. Strap on those headphones. We have Mike on the line. Mike, good morning. You're on Talkback with Dr. Tahta. Hi.
Yeah, good morning, Doc. What I really want to talk to you is about prostate cancer, because I know a hell of a lot more people died of prostate cancer than they did of lung cancer, by the way. So is there any other, because I have prostate cancer, and the fact is there any other test besides a PSA every 6 months, or is that just so go off and die someplace and don't bother me?
Well, thanks for calling in, Mike. Let me tell you something, though,
Thanks.
that it actually is lung cancer that kills more people than prostate cancer. You are right, though. Prostate is up there as well, and it is a bit of a problem in general. For prostate cancer, there's a young version and an old version. The version that afflicts young people is much more aggressive than old. Prostate cancer in patients who are in their 70s or 80s sometimes is so benign that it doesn't even get treated for some people. But you are right. It's a very, very common cancer, and that's why there are patients with the aggressive form, and they do die. What I would suggest is that you make sure that you're followed by a urologist. I mean, that's the best thing you can do for you. If new tests start being developed, it's the urologist who's going to know what they are and what the best way to follow you is. So my best advice to you is to make sure you continue to have a relationship with a urologist.
Question for you. So I had a friend when I was younger, and he had a father who was a baker. The father died really young, like in his 40s. And he said that he's always been afraid of baker's lung, which is something I hadn't heard about before. But apparently there's lots of jobs where you're dealing with small particulate in the air that can help you get lung cancer real quick. And this is something that these industries kind of know about now. Is that something you come into contact with, I assume?
Yeah, it's true. You bring up a good point. There are certain exposures that put you at increased risk. So the one that everyone knows about, because it's by far the biggest problem, is a smoking history. But what people know less about is that asbestos is a problem, and silica is a problem, and nickel is a problem. So diesel fumes is a problem. So these things less commonly cause lung cancer, but if you're exposed chronically over and over again to these things, you have a bit of a higher risk of lung cancer, even if you don't smoke. But because smoking is by far, the biggest insult to your body, if you don't smoke, but you're exposed to some of these other things, your risk still comes down. It's the smoking that's the big problem.
So maybe you can calm me down, because I've been kind of freaked out that I might get lung cancer for a while, because as a young man, I worked outside a lot, mowing lawns, etc., right? And it wasn't so much that I was breathing in diesel fumes. I was going too fast for that, probably. But I was, it's dry in Montana. All the particulate that you cut up goes up into the air and goes into your face. So you're breathing in small amounts of dust and grass all day long, usually. Right. Is that something that...
No, don't worry about lung cancer. There are some people who get who have lungs that are affected by that, but it's called a hypersensitivity reaction. So think of it as an
like
allergy.
Yeah, right.
Yeah, that's right. Obviously, that can be treated. You can try to prevent exposure. And that's a reversible problem. So there's no increased risk of lung cancer.
So why would flour cause someone to get lung cancer, but grass wouldn't?
It's just how the tissue reacts to these exposures. That's what it is. There's a certain type of lung problem called popcorn lung, where flour will actually affect the lung tissue. And there's a few other things that will affect the lung tissue too. Even though it's kind of rare, you can get something similar from e-cigarettes. So, e-cigarettes are okay if you're only going to use them to quit, but if you're going to use them as an alternative to cigarettes, they're not good. I mean, it's not a good long-term strategy.
What is the mechanism? Because cancer has always mystified me, because there's just so many different kinds of cancer. What is the mechanism that causes cancer when you smoke?
So that's a good question. I'll give you the general answer. So
okay.
It's similar for all cancers.
We don't have time for medical school here.
Yeah, right, exactly. So I'm going to give you a brief lesson.
Okay, all right.
Think of it as your normal cells mutating.
Okay.
That's the best way to think about it. Now, you might be genetically prone to that happening, or it might happen spontaneously, but think of one of your normal cells in your body switches and becomes a cancer cell. And then that thing knows how to multiply better than any other cell in your body. And it just grows from 1 cell to 2 to 4 to 8 to 16, and it just starts to form a mass. That's basically how it happens.
Okay, all right. So let's just say its survival mechanism is very powerful.
Very powerful.
Yeah. And
Yep.
and so to treat that once it's presented, how do you find it basically?
Well, so let me talk about lung cancer because that's an important point. Some cancers hide. Lung cancer is very good at this. And the reason why the lung cancer screening is so important for high-risk patients is because at the early stages of lung cancer, you'll never find it because you don't have symptoms. So this little thing in your lung starts growing and growing and growing, and it has to be pretty big, or it has to have spread somewhere else to lymph nodes or somewhere else in your body before you start to have symptoms. So you don't always know at the early stages that you have this. And why this is so important for lung cancer and some of the others is because we can treat and even cure the early stages. We cannot cure the late stages. We can try to control it for a little while, but we can never get rid of it.
Okay. We're up against a break, and we'll talk more about screening when we come back, all right? 721-1290 is our number. Dr. Stephen Tahta is joining us from Community Medical Center, a thoracic surgeon, and we're talking about lung cancer, very serious topics here. And our number is 721-1290. We'll be right back. Okay, welcome back to Health Talk. Dr. Stephen Tahta joining us in the studio. Let's get right to the phone and say good morning to Russell. Hi, Russell.
All right, good morning. Good morning, doctor.
What's on your mind, sir?
Hi, Russell.
Hi. You sound like you're pretty much at the forefront of advocacy for early detection and screening, and most of what you've talked about, I think people might classify as being in the quote-unquote old. Even some of the newer techniques you've talked about would be, I guess, maybe the new old, if you will. Just curious, particularly in the area of, say, small nodule detection, very early detection. You talked about lung cancer, particularly its ability to hide. If you've looked at any of the new proteomic blood test-based solutions in the adding that into the screening paradigm in your program.
Not quite yet, Russell. I mean, you appear to know a lot about this, which is kind of terrific. But it's coming, but it's not there for lung cancer quite yet. It is still the most effective way of detecting early lung cancer by imaging. So I'm actually hoping that one day we'll be able to figure it out with a blood test, but we're not there yet.
Okay, so now who should be screened for lung?
That was my question too.
Good, there you
good
go.
Who
question.
are the high-risk groups?
Right,
Yeah.
who's in the high-risk group? So the way it's defined is ages 55 to 80. And then there's
Check one.
Then there's two criteria. Either you've quit, and you've quit within that 15 years that we talked about, or if you're still smoking, you have a history of smoking 30 pack years. Now, what does that mean? The way that we do this as health professionals is we multiply the number of packs by the number of years you've smoked. So if you've smoked a pack a day for 30 years, that's 30 pack years. If you smoked half a pack a day for 30 years, that's 15 pack years.
Okay. Well, we have exactly 2 minutes left in the program. So let's talk about how to get in touch with you, what's involved with setting up a screening, that sort of thing.
So what I would suggest is that you come and talk to me first. There's some pros, there's some cons. I give you all that information, and then you can decide whether to be screened. It's a very easy test. There's no intravenous or dye injection or anything. You lay down on the table and you go through the CT scanner, which is just like a donut, and it's done in 15 minutes. But you can come and talk to me first to decide if you want to go ahead with it, and I'll tell you about the program because it does involve repeated imaging. So I'm over at Community Medical Center. You can reach us at 327-3819. 327-3819.
Now, is some of this genetic? I mean, if we have someone in our family who's had lung cancer, should we be? Yeah.
It puts you at increased risk. Now, if that's all you had and you never smoked, you're not in a high risk category. Interestingly,
Yeah.
But if you've smoked and you have a family history, makes it worse.
What if you're a baker?
That's a good question. But
Would that put me in the high-risk category?
But the work around a lot of flour and the inhalation of that particulate matter is not known to cause lung cancer that I've heard of.
Okay.
All right. So
Yeah.
there you go. Well, Dr. Tahta, it's been a pleasure. Thank you. And we'd love to have you on again if you'd like to come back on with us.
Great.
All
Thanks
right.
for having me.
Appreciate it. All right. And that's going to do it for Health Talk for today. We have Rob Nadelson joining us at the top of the hour.